right, welcome. After Sam Gituku, who is enjoying his last few moments of happiness, at least today, because on Sunday when Man City plays Manchester United, we are going to win. So it was an awesome political segment and, of course, political season. So you can make sure that more of that is coming up. And later on, if you missed it, you can catch it again between the hour of 9 and 10 if you missed the political conversation this particular morning. Well, today, like we do, it's health and nutrition. Today, it's health. And it's an interesting topic because even just by posting about it yesterday in the build-up, people are already asking me so many questions, both female and male. There are some who swear they'll never do something like a vasectomy. We're going to talk about birth control today. And we have Dr. Claire with us. How are you doing?
I'm fine, thank you.
Karibu sana.
Asante sana.
Uko sawa?
Sawa.
Yes, they still call you Daktari?
They still call me Daktari.
It's good to see you. Karibu sana.
Thanks for having me.
You know, when we are just after you posted yesterday that you're coming, of course I got so many questions, and we're going to talk about that later on. People have their own conceptions, misconceptions about birth control. But what are maybe the common ones?
Okay.
Yeah.
So it's difficult to say common because we have so many options.
Right.
So I can just summarize about the options that are available.
Right.
So basically you start off with, we range from natural contraceptives, and then we look at the more medical ones.
Right.
Natural just require for you to understand your menstrual cycle as a woman, and understand exactly when you ovulate and when the chances of pregnancy are highest. And then you use those days, what we call the safe days, and avoid having unprotected sex during that time. Yeah. When it comes to the artificial ones, that's where where your doctor comes into play, where we have the hormonal versus the non-hormonal options. We have short-term options, we have long-term options. We have options that have what we consider combined options. They have both estrogen and progesterone, and then we also have the progesterone-only options.
So estrogen and progesterone are?
The hormones that we use. So women produce both estrogen and progesterone in certain patterns and ways that control your normal cycle, that your body will know when to ovulate and when to have a period if you don't get pregnant. So when we use the hormones for contraception, we give you a bit of a higher dose of the two hormones or of progesterone only, and this stops you from ovulating. It also stops the lining of the uterus from preparing itself for pregnancy, and it also thickens the mucus at the cervix, and that is what will impede the sperm transport. So those three mechanisms together help you to prevent a pregnancy.
And so for them, then there's also so that's what is the pill, right?
Yeah, so the pill would fall under a hormonal method. So the pill, we have two types, the ones that have both the hormones in it, estrogen and progesterone, and the ones that have progesterone only. So depending, again, on where you are, and again, we have to discuss individual women differently, because there's no one size fits all, and there's no such thing as the best contraceptive. Something that works for me will not work for another woman, and also there's medical conditions to consider. We have to look at your age, your health, and how long you want to prevent pregnancy for. Are you preventing pregnancy initially, or are you spacing children after you've had a child? And then we also look at methods that are depending on your health and also convenience. Like if I have a busy lifestyle, I'm working day shifts, night shifts, I can't predict, it's difficult for me to take a pill every day at the same time. So I'll probably look at a method that is long-term, that is not as tedious. So it's very individualized, and it helps that women should learn to talk to their doctors first. Stop going over the counter, because you will end up with very side effects that we've heard about. That's where the myths come from. You'll hear a woman saying, I had a bad effect with this one, and so her friend will never use it, and yet for her it will probably have worked a bit better. So
it's individual. It can't be like, because it didn't work for Atieno, it will work for
Exactly, yeah.
Right. And then the other thing, so you mentioned that about pills. So are there different pills? Because I hear people, there is one who say that you take this one once a month and it works. Then there is the daily one that has sort of like a Monday, Tuesday, Wednesday sort of thing. So are they different, or?
There are different pills specifically. The ones we use medically, or the ones we recognize medically, are the ones that are used one every day for either 3 weeks and then you take a week off, or the one that you use continuously. Those are the ones we recommend when we're talking about the pill. The one that's once a month is controversial. We're not even sure exactly what it carries, and we've seen women come in with very bad side effects from it, so I wouldn't recommend it for anyone. But again, we are focusing primarily on women. We also have contraception for men. And believe it or not, it's easier for men to be the ones on the contraception.
Is it?
believe it or not,
Right.
you have a less complicated system. Sperm production is a month, it's usually in 3-month cycles, and so you know exactly when to inhibit it. As whereas a woman, it's an egg or a bunch of eggs being recruited every month and one being shed or lost every month if you don't get pregnant. So the cycle or the system in the woman is a bit more complex than in the man. Granted, because women are the ones who carry the burden of childbearing and looking after the home, the contraceptive burden is carried by women as well. But it would help if our men would help us.
Yeah, I kind of think it should change. Then naona hapa already kuna amana ananiangalia like sema
really? What do you
tusikie.
say?
So for men, what options are there?
So for men, we start with the very basics, barrier methods, the condoms. So those are easy to use, just requires discipline mainly. And there are different types and different styles of them now. So even for those who have allergies to latex or to the rubber, there are non-latex versions as well. There are different ones in terms of lubrication, in terms of sensitivity. So some people say they don't have sensation when they use condoms. We have lighter ones that have been produced. So you just need to look around in the market and see what works for you.
Right.
Then the next one is the common but also very notorious for failure is the withdrawal method. And that requires a lot of discipline, but also you have to keep in mind that there's such a thing as pre-cum, and so you can have some sperm that's released before ejaculation. So it's one of those that you have to talk about with your partner as well as with your doctor, because it works really well if combined with somebody who's on another type of contraceptive or is on natural contraception and knows her safe days, then it can be used effectively. Then there's what you consider more permanent option, and that's when you're completely done having children, which is a vasectomy, like you've said. For some reason, men are really afraid of this procedure.
There was a little test that was that I conducted via somebody else. So there's a group where they're predominantly women and mothers, and I asked them, go ask your husband or partner about the answer. Uchawi, kwani haunipendi. There's so many misconceptions about that.
The main one I believe is men believe it's going to affect their ability to perform, and that is completely false, because we don't touch anything to do with performance. It's basically just cutting the tubes that provide the sperm into the ejaculate. So even after a vasectomy, you will still perform normally, you still have an ejaculate, you have ejaculation, but inside that semen there's no sperm, and therefore pregnancy is not possible. So it's one of those really safe, really easy to do. Believe it or not, it's a clinic procedure under local anesthetic. 10 minutes with your doctor.
What? Okay, I didn't know that. Me, I knew when I go under,
no,
spend a day in hospital.
Unfortunately, it's the women. If women decided to tie their tubes as a permanent method, then they have to go in and be under sedation or a general anesthetic. But for men, it's a local anesthetic that's injected locally, basically pain-free. You have maybe 2-3 days of discomfort where you'll be pampered at home and taken care of like the king that you are. And then you're back to work and you're back to your normal duties and normal functions without any risk of pregnancy. And that's the only thing that changes. So in as much as men are skeptical, I would like to convince them that it's a safe method. And again, I'm insisting it's permanent. Yes, it can be reversed and there are procedures for that, but of course that's more labor intensive, it's more expensive, and that does require going into theater and having a general anesthetic. So you need to pretty much be at a point in your life where you're pretty sure I don't want to have more children.
All right, so we're going to ask you question if you have any questions yourself for Doc here as well. What questions do you have about birth control? What have you heard? Where do you need assistance and help? If you have those questions, again, like we said, if you use the hashtag, which is Daybreak, and you might be afraid of the question you're asking or you're not comfortable asking, then of course your name or your handle will be there. However, if you want anonymity, you cannot give your name. Just send us an SMS on 22422 and we'll share it without your name. But if you are confident enough, you can tell us your name and your location. It's okay. It's all up to you. What questions do you have around birth control? We're going to be able to, not we, rather she's going to answer those questions for you as well. Because the other thing, vasectomy, I'm sorry, because I'm a dude, just for the people, umantla. So it is reversible, but what would reversing it be? Because are you cutting the tubes? Are you tying them up?
So normally,
what happens?
The very basic is to find the tubes which are found within the scrotum, so we don't touch the penis at all. So there's no worries about changing function.
Right.
But then we cut the vas deferens, which is the tube that delivers sperm to the ejaculate, and that usually will be clipped, cut, and tied. And so depending on, especially the procedure itself, if it's tied, it's a bit easier to reverse. If it's clipped, it's a bit harder because there'll be a lot of scarring after the healing process. So we tend to want you to understand it's a permanent method. However, people who've had a vasectomy can still have children in other ways. So IVF now is an option, and where we would actually do sperm retrieval directly from the testes. So it's not that you've stopped producing sperm, it's just that they cannot travel. So we can go and get them ourselves.
Directly.
Again, you will be pain-free. So it's not something you'll be aware of.
I mean, just asking for my folks, man, my people. All right, so that's and then would you consider like also other methods, like people say you can, I don't know if, and correct me if I'm wrong, you can freeze your sperm and she can freeze, and then you just get the procedure, and then when you're ready it can happen again?
Yes, so for those people who would rather like preserve fertility even when they think, okay, maybe we're done now but we want to consider having a child later, or something might happen and we actually want a retirement baby or whatever the reason, yes, you can freeze sperm, you can freeze eggs, you can actually create embryos in the lab. So we actually take eggs and sperm, prepare the embryos, and then freeze at the embryo stage. So when you're ready for pregnancy, we will do the IVF procedures that get you ready, and we put the embryos back in and you carry the pregnancy.
But it sounds expensive.
It is.
Yeah.
It
All
is.
right,
But unfortunately,
and how long can they last?
Usually now with the good freezing processes that we have, up to 10-15 years viability. But again, you'll always be charged sort of on an annual basis for storage. So it's something that we're not going to say it's your primary way of conceiving, but for those who are having difficulties or for those who are limited, then we'll probably consider that as an option.
What about the coil for the ladies?
So we have two types of coils. We don't, medically they're called the intrauterine contraceptive device. The IUCD. So the IUCD is nowadays in two forms. We have the copper ones, which is non-hormonal, and we have the Mirena, or the hormonal one, which carries progesterone only. So the difference between the two is that with copper you have a longer period of time for coverage. We have different types now where the dosing on the copper is a bit different for different ones. So you can have it for a 3-year period, for a 5-year period, or for a 10 to 12-year period. And then for the Mirena specifically, it's a 5-year period. The good thing with the IUCDs is they're inserted into the uterus, and so they are fuss-free. Once you've had the procedure, again, it's a clinic procedure done by your doctor, your gynecologist in the office, and once the procedure is done, you're pretty much protected. They'll be able to talk you through when exactly to come in during your cycle, but once it's inserted, for you, it's fuss-free. You don't have to keep checking your coil, you don't have to worry about conceiving. There's the annual checkups that you should have with the doctor to make sure it's still in position. There are signs and symptoms that we will teach you about in case it's displaced, so that we prevent that risk of pregnancy. But the good thing with the IUCDs, they're considered the best in terms of lowest failure rate. With the copper one, it's about 99.2% effective, and then for the Mirena it's 99.8. So just used properly, and as long as it's in the right position, it does work effectively as a long-term contraceptive option. Another important thing to understand about it, the main difference between the two, when we talk about side effects, with the copper one, it's more likely to give you a heavier period or painful period. So if you had cramps or you had heavy bleeding originally, it's probably not the method for you. And then the Mirena works the other way around. So if you're a woman who's looking for a contraceptive and you already have issues with heavy periods or very long prolonged periods where you have a lot of period pain, the Mirena or the hormonal one would actually be a better option for you, because it thins the lining a bit more than the copper one, and so you get less flow and you get less pain. So we tend to use it especially so for women who have other gynecological issues. Again, with hormones, you always have to factor in your health. So people who have long-term conditions, lifestyle conditions such as hypertension, diabetes, we have to be very careful. If you already have other gynecological issues, some will make it that you can't use one type of contraceptive versus another. So it's important to also have, again, I keep emphasizing, talk to your doctor first. Have that conversation. Let's do the history taking where we check and assess you for all the risk factors, because generally speaking, contraceptives are safe, but then you'll have individual risk factors. The hormonal ones, for example, some of the most severe risk complications that you can have on it, or any of them, so from the pills all the way through to implants, injections, and if you think about the hormonal IUD, the biggest worst case scenarios is a risk for strokes, for heart attacks, and for forming clots within the legs and throwing an embolus into the lungs, which is catastrophic. It's life-changing. I mean, it can be life-changing, can be life-threatening, can actually cause death. In those scenarios, it's because of risk factors that put you at a higher risk than another person. So genetic conditions where you have clotting issues would put you at higher risk. Somebody who's heavier or obese would actually be at very high risk. Somebody who's a heavy smoker or uses other types of drugs, somebody who's a heavy drinker. Those will put you at very high risk for using hormones. And so if you went over the counter and took the pill by yourself without that assessment, you actually put yourself at risk, and it actually can cause death. So the advice is please go in and have a conversation first. Everything is available in Kenya very easily, but that doesn't mean you should just decide on your own. Yeah.
And so then there's also the, you talked about implants, injunctions. What's the difference?
Okay, so again, delivery options are different. The way you take your contraceptive is where it depends on your lifestyle, it depends on convenience, and as well as other risks. So some women are comfortable taking a pill every day, and they have that discipline, and they're able to set an alarm, and they're able to keep up with it because their schedule is pretty predictable. Other women find it difficult, or some of the side effects like nausea and feeling fatigue, or some women get breast tenderness, makes them feel, I can't use that type of a contraceptive. So for those ones, we would then say, think about a longer term option or a different delivery method. So you can have an injectable. Some you go in monthly, some you get every 3 months. You can get implants, which we put in the skin in your non-dominant arm. So it's sort of discreet. It's not something everybody can see, but it gives you a small dose of the hormone every day. And that
How long would that?
So we have, right now in the market, we have two. So there's a 3-year one and there's a 5-year one. So it will deliver the hormones slowly over a period of time. And yes, the side effects are pretty much similar, but the delivery system is what is different. And then now what we've talked about with the IUCDs.
Right.
Yeah.
Right. So of course, with all this, you mentioned some of the side effects that may be there. And as expected, that's one of the questions that we ask, and we see here on SMS. Somebody asked, are there long-term effects of prolonged use of injections for birth control in women?
Right, so there are no real long-term effects of any contraceptive method, except when you say permanent. So when we do the surgical ones, the long-term effect is you'll probably not get pregnant again. For the others, they're all reversible. So the minute you take it out, or if you had complications with any of them or side effects with any of them, the minute you stop using or take it out, depending on the type you're on, more likely than not, the side effects should reduce. Some will take a bit of a longer time. For example, the 3-monthly injectable, what we call Depo-Provera, it's notorious for stopping your period during the time that you're on it, and then once you stop using it, it takes a few months before your cycles come back to normal. So it would not be an advisable method for somebody who's looking to conceive immediately they stop the method. So you will need to give your body a bit of time, depends on your metabolic rate as well, so that you give it a bit of time to clear the hormones from your system, but then your cycles should come back to normal, usually within 3 to 6 months. So there are some methods that take a bit of a longer time. The pill, for example, if you stop it at the end of one cycle, the next cycle you're ovulating immediately. So we consider it a very short-term method. So they'll vary, but then long term, it's very unlikely that you're going to have serious complications.
And so just as a follow-up question, so when should you consult your doctor? Like if after you've stopped and it's taken maybe 2 months and you haven't got your period, when should you be worried?
Okay, so again, you should be working as a team with your doctor. So even the stopping should be under advice and under supervision. And so if you're deciding, I'm not going to use my contraceptive anymore, come in, we have that conversation, we get you to stop using, so we don't give you the next injection that's due. And then we watch out for the side effects so that your doctor is constantly aware of what you're suffering or any issues that you're having. Generally speaking, as a rule, 3 to 6 months, if you're not being, especially if you're trying to conceive. So within the first 3 months, if nothing is happening, then you should come back in and let's have a conversation. Yeah.
All right. Take a look at another question. When will one know when the menopause hits to stop for the pill? She says, I hope it's a she, right? Yeah. She says she's 56 years and she's still on the pill.
Okay. So again, The gap here is not talking to your doctor.
Right.
I've overemphasized that one.
Right, yeah.
So with the pill, it's difficult to tell when you're going into menopause because, like we said, we're giving you hormones externally, and they're higher dose than what you normally get. So probably she's still having a very regular period, which if she was not on a hormonal method at all, her period would have started to change, and should have been noticing I'm missing a period every few months. So usually, normally, we go into menopause, generally speaking, from about 48, perimenopause.
Right.
Between 48 and 52, and then you gradually stop getting your period completely. Perimenopause is where your period is erratic. Every 3 months, every 1 month, it's just, you can't predict anymore. Whereas now full-on menopause is you've gone a whole year without getting your period. So for somebody who's 56, my advice would be go in and see your doctor, and let's take you off the pill so that we can actually observe whether or not you're getting cycles on your own. Because while she's on the pill, for sure, she's getting very regular cycles.
Right.
Yeah.
And it's because of the hormones.
Yes.
Right.
Yes.
All right. Someone says, I've been using an injection for 3 months, but shida mingi periods through. What can be done to stop the menses? Okay. Yeah, she's been using the injection, but she's
getting non-stop bleeding.
Yes, non-stop bleeding.
Yeah.
Yes.
So it's one of the common side effects of the long-term hormonal methods is changes of your cycle. For some women, they'll have persistent bleeding, either spotting or just non-stop bleeding throughout. For other women, it completely stops their period. Depending on what the side effects is, most women don't mind if their period stops coming because you stop paying money for sanitary wear, you stop having the symptoms during your period, so you're comfortable with that. If you're having erratic bleeding, if you're having persistent bleeding or spotting, come in immediately because there are several medications we will put you on, sometimes also hormonal, to just counterbalance what you're on so that we get your cycles back to normal. The normal is when whichever contraceptive method you're on, either you don't get a period at all or you continue to have a monthly cycle like you had before. So that persistent bleeding is definitely problematic. Yeah.
So what would be erratic bleeding?
So either you're having, you can't have a predictable, so normally a woman will have a monthly period. Right. So every 21 to 35 days, you have a bleed. If you're on a contraceptive method, majority of them will give you a 28-day cycle, 30-day cycle. So that's what we call normal bleeding. So you should be having a period every month. Okay. But then now if you start to have, I'm bleeding every week, it's non-stop, or in 2 weeks' time, another bleed comes. In another 3 weeks, I have a bleed, so I can no longer predict. That's what we're referring to as erratic. Or if you don't get a period for 3 months and then it comes and it stays for 2 weeks, that's also not normal. So all of those should cause you to come in and see your doctor so that they can be able to address the issue. Sometimes we are able to manage that bleeding. Sometimes it just means this is not a method for you, so we change you to something different. Yeah.
All right. Mimi natumia pills daily. Is it okay? Juu nasikia fununu inaweza kuweka growth kwa tumbo. That's what somebody asked.
Okay, so with the pills, like I said, there are different types of pills. The one that's a bit problematic is the combined one. The one where you're supposed to take it for 3 weeks continuously and then you get a break for 1 week, or you take iron tablets during that week. For that one, it has both estrogen and progesterone. Long-term use has been found to have risks for cancer, some types of cancer, so ovarian cancer, breast cancer. But again, it goes in tandem with other risk factors. So if you already have a family history of those kind of cancers, you really shouldn't be on the pill to begin with. Right. But then generally speaking, we don't want you to be on the pill for more than 10 years without checkups by your doctor so that we have assessed you for those risks. If you are unsupervised, go in now so that we can actually assess. But then long term, they're generally safe because most women don't use them continuously and also take breaks for pregnancy. But you should actually not be on it for a very prolonged period of time.
All right. Someone says, is it normal to have, I think you answered this, but someone says, is it normal to have periods 3 times in a month? Now that I need a baby, help please.
It is not normal to have your period more than, especially if it's a cycle that's shorter than 21 days. Sometimes it can be 2 times in a month just because we're not looking at the calendar month, we're looking at the number of days between your periods. So if you're getting a period less than 21 days or more than 35 days apart, you should come in for a checkup. What it basically tells us is that you're not ovulating as you're supposed to be ovulating. You're not having a regular ovulation as your body is supposed to do. In that case, getting pregnant is very difficult. So come in, have an assessment, and we'll be able to see what exactly is causing you not to ovulate regularly, and if we're able to correct it, we start to do the work together.
There are also people who already have, and I'm just thinking some of the comments I saw yesterday, I probably have to open my Facebook page, heavy bleeding, just normally when they're on their cycle. So would they, what kind of contraceptive would work for them?
So a longer term contraceptive probably progesterone only would work much better. Like I said, for example, the hormonal IUCD works really well for those women who have very heavy periods. It helps you thin the lining, and therefore your period becomes lighter. For some women, the injectable will also stop their period, or the implants will also stop their period. The thing about the pill is it gives you a very regular cycle. So if you already had a heavy bleed, it might continue to persist while you're on it. So again, it's basic, comes down to individual. There's no one size fits all. Even the advice I'm giving here, it's generally speaking. If you come in for a review, we'll be able to assess you for your individual issues. And so if your bleeding is being caused because of a contraceptive, we change the contraceptive. If it's a natural issue, we address what the cause is. For example, some conditions such as fibroids can cause you to have very long, prolonged periods that are very heavy. We're not usually using some types of contraceptives with someone who has massive fibroids. The fibroids have to be addressed, and then the bleeding issue will probably go away. So we have to assess you fully and see, is there something else that's causing you either not to ovulate or to be having very heavy periods or very prolonged periods. And a prolonged period means you're bleeding more than 7 days, just to be strictly speaking. So if you're having any of those symptoms, come in and we assess for other issues that may be causing them, and not just assume it's my contraceptive or will a contraceptive help for that. You actually need to look at the underlying factors.
So what would it look like? So if, let's say, a lady or a gent is to walk in, what would the review look like the preparation to determine what is best for them?
So we encourage couples to come in together, but some people are a bit more sensitive. Some people, it's very culturally inappropriate, or their belief systems don't allow. So we also still engage with women. You don't have to come in with a partner if you don't have one or don't want to. But it does help if you have a partner and they can come on board, because they'll understand a bit better about the side effects and the issues that you're going to maybe experience during the time you're on your contraceptive. And then when you come in to see your doctor, I always encourage patients, come prepared. Do your research, write down those questions. Let's address all of them, because I can't read your mind and I'm not going to be able to assess you or understand fully what your concerns are if you don't understand them yourself. So come prepared. Think about what options do you want. There are factors I always encourage that you think about. How long do you want to postpone the pregnancies? Convenience, lifestyle. Are you somebody with discipline or somebody who wants a no-fuss method? I don't want to actually think about my contraceptive. In terms of side effects, you want to know, is this one have more side effects than this one? If I have a medical condition, is it contraindicated? Is it something I should be using or not using? Come with those things in mind. And then the misconception I see with a lot of my patients is that they come in thinking, Daktari will tell me what to use. It doesn't work like that. We have to look at you as a whole person in terms of your health as well as your lifestyle to determine what would work for you. And so again, it's teamwork. So don't come in saying, Daktari, I want the best method. I can't predict that for you. So your doctor should be able to walk you through systematically all the options available, or if you have a specific one or two in mind, we narrow down to those ones. We discuss them in detail. As you're making the decision, again, I also have to encourage a lot of women, it's not permanent. Until you get to the point of tying your tubes or a vasectomy, it's not permanent. If you have side effects and it's not working, come back in, we change it. There's no ati nimeambiwa jikaze. It doesn't work like that. So if you're having real issues, if you're having bleeding issues, if you're not comfortable not getting your period, come back in immediately. You don't have to keep any method. Yes, it's a 3-year plan, but after 3 months, hainisaidi ID, so let me change the option. So you can change your options. We are lucky in Kenya that the policies were created early enough that a lot of contraceptives are available for free or subsidized, especially so in government facilities. So you can come in and have them changed until we find something that works for you. Again, come in with an open mind. So don't come in and be told what to do. That is the wrong approach. I've seen it a lot, mostly because healthcare workers don't have the time, because you're seeing so many people. But insist, you have the right to ask questions. You have the right to sit there and discuss what potential side effects there are. Because I find that you manage them a bit better. If you never told me, I'll bleed for 3 weeks on this method, when it happens, the panic that will happen. So you need to actually take the time to understand what option you're picking. And then once you've selected it, see if it's working for you. The other thing is, a method that worked when you were younger or before you had children might not work again after. If you're spacing and you find you have side effects on it, it might be time to change to something different. So it's, again, even for you, it's not one size fits all. As you change during your reproductive years, you'll also find that you need different methods.
All right, we have some other question here. Can one with varicose veins use contraceptives?
So yes, but we encourage more natural methods or non-hormonal methods just because of the way varicose veins work and the other risk factors that come with that cause varicose veins themselves. So we would encourage, again, a direct consult so that we assess. We usually will work together with your physician, the one who's looking after you for the varicose veins, or your surgeon in case you needed procedures, and then we'll be able to see. If you have other medical conditions, we put you on the right contraceptive. But I would lean more towards natural options or non-hormonal options.
I guess this one you answered it a little bit, but somebody asked, what are the chances of getting pregnant with a copper coil IUD? There have been so many memes as well online of children who beat it.
Come out holding it.
Come out holding it like, yay, we beat it. So what are the chances?
So it has, believe it or not, it has the lowest failure rate.
Oh, wow.
Because like I said, it's 99.2% effective.
Right, that's for the
copper IUD.
Yes.
So when it comes to where it fails, it's usually a loss to follow-up type of situation. So I tell you, it's a 10-year plan. You come, we put it, and then whew, never see you again until there's a pregnancy. Usually we have reviews after. So after a month, we come back in and check to make sure, because usually the first period will be pretty heavy. So within the first month to 6 weeks, we want to review and do a scan to make sure it's in position. The coil is only effective if it's in the right position in the uterus. You will never be able to tell as an individual, my coil is sitting in the right place. We actually have to do scans to look at the positioning. Even the old school thinking of you feel the string so it's in position, that doesn't tell us anything. It just tells us it's there. Internally, it could have shifted downwards or to the side, and when that happens, it's not effective. So we have to have those constant reviews. Usually, we encourage that after your initial reviews with the doctor, and once it's settled, at least once a year, you should be having your IUD checked. If you have strange symptoms in between that time, where you have abnormal bleeding in the middle of your cycle, or you have abnormal pain, lower pelvic pain or back pain, it's time to go in for a review, because those can be symptoms demonstrating that it has become displaced. If it's displaced, you can conceive, and if you do conceive with an IUD, we tend to leave it in place until the birth, so it comes out to the baby. So those memes tend to be a little bit correct.
They actually, I didn't know that. So yenyewe mtoto anatoka kama ameshikilia. It could be something else. All right, wow, that's interesting to know. Can someone with less than, okay, this is definitely up your alley, because I don't know what this is, 15 fibroblasts get pregnant?
Less than, so I think they mean fibroids.
Yes, I think so.
So again, fibroids, it's not about number, it's more about the location. So where they are in the uterus. If you have fibroids on the outer part of the uterus, it's unlikely they'll give you issues during pregnancy or conceiving and carrying a pregnancy. If you have fibroids closer to the lining or within the cavity, or if they're within the muscle of the uterus, they usually will cause a lot of bleeding, a lot of pain, and cause, because the cavity usually is supposed to be straight. So sperm transports itself along in a very straight, finding itself in the cavity all the way to find the tubes. If you have fibroids that distort that shape, it's harder for them to find the tubes, and so there's a higher risk of ectopics or just not conceiving at all. So if you have fibroids, you need a review, because there are those women who they're very small, they're not in the critical parts of the uterus, so we let them conceive and we follow up as they carry the pregnancy, and usually not problematic. There are those who have very big fibroids, the uterus is completely distorted, it's changed in shape and size, and the cavity is completely distorted. We probably have to do surgery before you can try for a baby.
Right.
Yeah.
All right. Is it true that implants you use on the arm affect the fertility of women?
So that's a good question, because that's another myth that we have. So about the injections and the implants, they're long-term progesterone-only options. And like I said, every option is considered reversible. But because it's a hormone being delivered to your system, as a different individual woman, your metabolism is what we will rely on once you stop the method to clear the remaining hormone.
Right.
So for some women, it takes a bit of time. For others, it's immediate. So you can come off the implant and the next month you're ovulating and you're able to conceive, whereas another woman will take another 3 months or so before they're able to get regular cycles.
Right.
The main indicator that your hormones are cleared from the system is your cycles come back to being regular. So if your period is very, very regular after you've taken out your contraceptive, then it means you're more likely than not ovulating, and it's unlikely that you're going to have problems conceiving. Yeah.
All right, let me take some Ibra from my Facebook, because that's quite interesting. And this is another thing as well, because we are finding more and more use of this, and this is a question. Do these birth control measures have any side effects on young adolescents, and what are the risks associated with it? How are you, and then also, because there are different myths, how can we reduce myths about contraception in the community? Yeah, okay, that one we can also talk about. But there are a lot of, let's say, younger people, 18, 19, 20. Is there different risk factors for them because they're young, or can they also just safely use them?
So with the majority of the options, it is very safe for women to start them. We start some of them as early as 16, 15, because again, you have to remember, sometimes we use contraceptive options to manage other gynecological issues.
Okay.
So if you have younger women who have issues with their cycles, they're having very prolonged periods or erratic bleeding, then we might put them on hormonal methods to help regulate those cycles. So they are safe. Now, the controversial side of it is whether or not they should be using. The thing that's not safe for a teenager is pregnancy. Your body is not ready, the pelvis has not formed adequately, and your body is not actually in a healthy state to carry a pregnancy. So those unwanted pregnancies put the girls at risk for even death. So many complications can arise during the pregnancy, during the birthing process. So we actually find that contraceptives will be safer than an unwanted pregnancy.
Right.
And I'll always emphasize, most of the contraceptives we're talking about do not protect you from sexually transmitted infections. So it's important to understand that condoms are still vital. Barrier methods, there's the female condoms and the male ones. They are vital for you to be able to keep yourself safe. So some women will be on one form of contraceptive for birth control, but they still probably need, especially if you have multiple partners or there's a risk with your partner, then you should probably be using condoms as well as the other contraceptive that you're on. Yeah.
I've seen one there for the men asking, does having a vasectomy cause erectile dysfunction?
No, it does not.
Okay.
At all. I can't emphasize that enough. The only thing that stops is sperm moving from, not even sperm production, you're still producing sperm.
Okay.
It's the ability to transport the sperm from the testes all the way to the ejaculate, which is the semen, and then that's what is delivered during ejaculation to cause a pregnancy. All we do is cut off the sperm transport, and those tubes have nothing to do with performance. Erectile dysfunction is not one of the side effects that you get from a vasectomy.
Okay. What are some of the side effects?
So immediately after the procedure, there tends to be discomfort and a bit of swelling, of course, because you've had a surgical procedure, but the incision is tiny on the scrotum, so it heals very quickly. You will probably need a few days off work. Usually, if you have it like on a Friday, by Monday, you're back to work as normal.
Damn, nice, man. Told the boss. No, someone was going to sign for a week.
No.
Okay. All right.
But again, you can sweet talk your doctor.
Right.
There's always that. But then once the procedure, during the actual procedure, it's pain-free because we give you a local anesthetic, so you will actually not feel much or anything during the actual procedure. But afterwards, as the anesthetic wears off, we send you home on a painkiller. But it's not pain, it's going to be discomfort. It'll feel like someone hit you, but not the way you guys fight.
Yeah, I was just about to say, yo.
Like that.
Yes, okay.
So there'll be a bit of swelling, a bit of redness, a little bit of tenderness or discomfort, but then an ice pack and relaxing for those 2-3 days, you're back on your feet, like you will forget. The key thing is, it takes a bit of time for what had already been produced or to completely be cleared.
Okay.
So we do tell you for, there's a timeline, so usually we'll come back in for testing to make sure that the semen is not having any sperm at all. From that point on, you can safely stop using condoms. But in the interim, it's important either your partner is on a birth control method or yourself, you're using condoms.
So you don't just get it and then Monday, Tuesday, you're back at it.
You will get pregnant.
Okay, all right. Okay, all right. So, yeah, tafadhali, mchunge kidogo. All right, let's take a look at another question here. So, I stopped taking daily pills in August, hoping to conceive, but I haven't. What could be the problem? I think this is August when? Last year? Probably, yeah? Yeah, and until now, which is March, they still haven't conceived. What could be the problem?
So, contrary to popular belief, the human person is not able to conceive every single month.
Right.
In a year, we have a 70% chance to conceive, and normally, without even interference with contraceptives or ever using anything. So it's not that every time you decide, I want to conceive, automatically you're going to conceive immediately. Depending on age, we give you about a year. So up until 35, younger than 35, we give you a year to try on your own. Don't stress about it, because again, stress hormones will also interfere with the process of conceiving.
Right.
So trying for a year, especially if, like I said, lower than 35 or less than in your 20s, basically, you should be able to get pregnant. But then after 35, we reduce the period of time because there is evidence that our fertility as women drops significantly from 35. For men, it drops significantly from 60.
Why? So to go for the Abraham. Yeah.
So for women, if you're coming off a contraceptive, give yourself a bit of time. Stop stressing about it. Have a bit of fun with your partner so that you make it a delightful process.
Yes.
You're more likely to conceive that way.
So it's not like work.
No.
Yeah.
If it go beyond 6 months, if you're more than 35 years old, then come in for a consultation. We'll be able to assess and see, because more likely than not, people will believe that it's because of the contraceptive, but there could be other underlying issues that are causing you not to conceive. And so we test for those for both you and your partner. Another thing about conception is a big misconception is it's always the woman's fault. That is not true. Sperm production and release is actually more affected by lifestyle choices. So men who drink heavily, smoke, use other types of drugs. Nowadays, we're smoking weed much more than ever before. So
they are. Right.
They are.
Yes.
So in those scenarios, the sperm that's produced within those 3 months is going to definitely be affected. It's not just about production of sperm. You don't just have sperm. It's whether they're moving. Some sperm just chill like this.
Right.
They dance over here. They don't move at all.
They don't go. Right.
Others will move, but in opposite directions. Others are deformed when they're produced because you're constantly producing a fresh batch every 3 months.
So drinking and smoking and weed affects this?
Yes.
The movement?
Yes, yes, and also other medications. So if you're hypertensive, if you're diabetic, if you have other medical conditions, there are medications that you can have been on that will affect the production of sperm. So we do test both partners. A lot of women come in on their own and say the partner can't be tested, and then we find there's nothing wrong with her. So it's time to bring in your partner. Right. Yeah. So it's not always that it's the woman who's having an issue. So in this particular case, if there's a concern about trying to conceive, I would advise that both her and her partner come in for a checkup, and then we can be able to take it from there.
Right.
Yeah.
Right. Somebody else is asking a question here. Why do some family planning methods lower the sex drive in women, libido?
Right, okay. So because of the hormones within them. So it's usually that it's a hormonal method. And like I said, we're giving you a higher dose than what your body would produce normally. So for some women, it's that it reduces the libido. It can also cause side effects like mood swings, breast tenderness. Some people get initial nausea. Some will actually have vomiting. Some will get headaches, fatigue. All those are common side effects, but they tend to wear off over time. Libido changes. Some women, it increases the sex drive. For some, it reduces. So again, depending on the method you're on, if it's a significant side effect for you, come in and let's talk about a different option that wouldn't affect your libido as much.
Right.
Yeah.
All right. Also, we have, after my last shot of Depo, I haven't seen my period in 3 months now, and she's not pregnant. Yeah.
So like I said, that's a very common side effect of the injectable. The Depo-Provera is an injectable option. In that particular case, it's not anything to worry about, because the way the contraceptive works is it stops you from ovulating. When you're not ovulating, your body is not told to prepare for pregnancy. So the lining of the uterus doesn't thicken, and so there's really nothing to shed. And so you'll find that you don't get a period at all during the whole duration of time that you're on that method. So if you keep getting your injections every 3 months, it's unlikely your period will come back. But once you decide to stop on that method, then you can continue to, you can expect your period will come back and come back as normal.
Right.
Yeah.
So I think that also answers the next question, because they're also saying they've used it for the past 6 months and they haven't seen their periods. So that answers that as well. Let's go to the next question. Or I can pick it from, there is somebody here says, can a person with a cyst on the left ovary use birth control? And this one is asking, she's actually tuned in all the way from Uganda. Oh, nice. Yes.
So it depends on the reason for the cyst. So again, this is another misconception that all cysts are problematic. We have a cyst every single month if you're ovulating, where the egg has been released and the cyst is sitting there waiting to see if you get pregnant or not. In that case, the cyst will then start to produce the hormones that support the pregnancy. And so it's not that it's an abnormal cyst. There are those cysts we call functioning cysts, and they're normal. And you'll find that if you come in every month for a few months to your doctor, during the time of ovulation, we'll find a cyst in one of the ovaries.
Right.
Then we have abnormal cysts, the ones that persist beyond what is normal, because by the time your body registers that you're not pregnant, the cyst will disappear and you get a period. In that scenario, if it persists after that, then it becomes problematic. And some of them get really big and they're quite painful, or they can change your cycles. Those are the problematic ones, and we would not advise that you use a contraceptive. You'll also be pretty uncomfortable, so it's unlikely that you can decide, okay, let me just continue with normal life and use my contraceptive.
Right.
So if you do have symptoms and you come in and we tell you it's about a cyst, some of them can be managed medically, others have to have surgery. So again, it's on a need basis and we assess you individually. In her particular case, I'd have it assessed first and then you can make a decision about contraception.
Right. All right. Well, I see we're kind of out of time here, but so for the rest of you, with your many questions, I guess Dr. Claire will tell us how can they get in touch with you, where can they find you? Yes.
So I'm a very sociable person.
That's right. Yeah.
I am on social media. My handle is They Call Me Daktari, and that you'll find on Instagram as well as on Facebook. It's at Claire Noni on Twitter, but I barely ever. KOT are scary.
Yes, yeah, KOT.
Yeah. But then email, or my clinic is in Upper Hill, so I'm available at Prime Care Health Services, which is in Upper Hill. They can always reach out on email, primecarehealthservices@gmail.com, or they call me daktari@gmail.com. And I'll be able to get back to you. We can always book in an appointment. We also have started to do, because of COVID, where we have virtual consultations, so we can talk to you via several means, and I can always discuss that with the patients. Yeah.
And this is Daktari D-A-K.
Yes,
Daktari.
Kiswahili.
Yeah,
Daktari.
Kiswahili Daktari. They call me Daktari. So I hope this conversation will be helpful. As usual, of course, we can't answer all your questions. So let me just thank you for all of you who've been sending in all of your many questions. And of course, you can reach out to her with the rest after this. You can catch it. In case you are catching this in the tail end, you can catch it later on YouTube and see some of the questions, some of what she talked about as well. But do reach out to her because, like she said, and she can't stress it enough, she said, lazima uongee na daktari kwanza. Hii mambo ya kusema, all right, babe, tuanze, and then you go over the counter and get a pill. You don't know what you're putting into your body. You don't know, especially what your underlying conditions are. You might not know your history, so the conversation will help. I hope it helped you, and I hope for the men who are watching, you have been encouraged somewhat, or some fears have been allayed in terms of getting a vasectomy. Can't even say it because you're not used to it. A vasectomy. Maybe it's an idea. But thank you so much for making time for us.
Thank you.
And make sure you follow her. It is at They Call Me Daktari. Ukipotea sana, niambie, nitamtafuta. All right? So, peace and love. Coming up next in this hour, like I said, if you missed the interview earlier on, Sam Gituku and the panel on politics of the day, inclusive politics it's going to come up in this hour. So, successful people look like you, and as we will see on Sunday, the great Manchester United. Peace and love.